I would now request Rotarian Swati Jajodia to introduce our guest speaker, Dr. Natrajan. Swati?
Sorry, just a very good afternoon to all. I would like to start by saying, where words are restrained, the eyes often talk a great deal. Samuel Richardson. It is my privilege today to introduce our esteemed speaker, Padmashree awardee, Professor Dr. S. Natarajan, an ophthalmologist who has dedicated his life to bringing back the light in the eyes of thousands. I have known him personally for over 6 years, and I yet have to come across a more driven and jovial person than him, be it his professional or humanitarian endeavors, or commitment to his health, or even to his late grandmother, fondly known as Achi. He has always given it his 200%. Over the past 36 years, he has performed over 60,000 vitreous and retinal surgeries. Dr. Natarajan has trained more than 68 vitreoretinal surgeons across the globe. One of his very distinguished achievements is performing over 200 complicated VR surgeries on people injured by gun pellets in Kashmir in 2016. Within 2.5 days, he performed a record number of 47 VR surgeries, for which he was felicitated by the government of Jammu and Kashmir with the State Award for his meritorious public service. Professor Natarajan has been a charter inductee in the Retina Hall of Fame. He is invited to teach as well as speak at prestigious universities across the globe, and his work has been published in hundreds of international journals. He has been honored with a Doctor of Science degree from Savita University. In the past 3 decades, he has served in various capacities on the boards of world renowned organizations. He is also a recipient of several other international awards for his exemplary work in the medical field, which includes Gusi Peace Prize Philippines and Man of Millennium Award by the Visitex Foundation. The list is endless. Dr. Natarajan has also established a non-profitable public charitable trust, Aditya Jyot Foundation, for Twinkling Little Eyes in 2005. The foundation runs outreach programs in rural as well as urban slums and tribal areas, which strive to provide quality eye care for the underprivileged. The latest news is that Aditya Jyot Hospital has merged with Dr. Agarwal's Eye Hospital, Mumbai, as on October 8, 2021. The foundation has run several hundreds of diabetic retinopathy camps, screening over 70,000 adults and over 60,000 children. Via door-to-door campaigns, the foundation has covered over 2 lakh households and over 1 million people in slums and performed over 5,000 free surgeries. The Aditya Jyot Foundation is committed to reducing both avoidable and unavoidable blindness. Their vision is to establish cutting-edge technology to understand the biomechanism of eye diseases and to discover novel therapeutic approaches, including regenerative medicine. The record of maximum diabetic eye screenings in 8 hours is 649, and the same was achieved at an event organized by Dr. Natarajan, Dr. Radhika, and Aditya Jyot Foundation at Dharavi on 2nd Feb 2019, and the same has been documented by the Guinness World Records. Dr. Natarajan is the third generation ophthalmologist, son of Professor Dr. N.S. Sundaram, who was his inspiration in starting various clinics in Maharashtra and Chennai. All three of them studied at the Government Ophthalmic Hospital and Regional Institute of Ophthalmology, Madras. The clinic in Chennai is dedicated towards research in the field of hereditary eye diseases. Let my soul smile through my heart and my heart smile through my eyes, that I may scatter rich smiles in sad hearts. Paramhans Yoganand. With this, I hand over the stage to Dr. Natarajan to speak to us about retina detachment, a particularly debilitating eye condition which many are afflicted by. He will talk to us about why it happens, treatments, cures, and the precautions to be taken after a retina surgery. Over to you, Dr. Natarajan.
Thank you, Swati. So I'm just putting my timer so that I know when I will have to start. So thank you very much, Swati, for the introduction. I'm sharing my screen. So I have a presentation. So thanks for asking me to speak on retinal detachment. Usually public talks are not on this topic, but it's, as you said, very important. At the outset, I want to thank my Dr. J.D. Polnichkar, Dr. Aishwarya Iyer, Dr. Prasanna Venkatesh, my optometrist Rekha, Samir, and my executive, and also the two doctors. When I was in Chennai, I told them I want to give a talk to the Rotarians, so they gave me Dr. Atul Dhawan and Dr. Matangi, who has joined the meeting now. So introduction, what is the human eye? And I think all of us know that it receives the images and sends to the brain, and that's the, and you see the retina is a light sensitive layer, and I have a video to show so that it will give the idea of the introduction to retina, and then we'll understand what is retinal detachment.
Vision is one of the most important senses. The eye's main function is to detect light patterns and partner with the brain to translate light into images that we see and perceive. The eye is a complex optical system very similar to a camera. The lens in the eye focuses light onto the retina at the back of the eye. The retina functions as the film in the eye's camera, capturing incoming light rays from objects and sending them to the brain to be developed as an image. Let's explore the eye's lens and film and get a closer look at the structures in between that allow us to see. The process of vision begins when light rays bounce off an object and enter the eye through the cornea, the clear, dome-shaped front window of the eye. Similar to a lens on a camera, the cornea is a powerful refractive surface, 70% of the eye's processing power. It is the cornea that enables us to see clearly. After traveling through the clear cornea, the light rays reach the iris, distinctively colored part of your eye that you see in the mirror. The pupil is the small opening in the center of the iris that acts like a camera. As muscles in the iris relax and constrict, the pupil changes size to adjust the amount of light entering the eye. The more light your eye is exposed to, the smaller the pupil. If there is low light, the pupil enlarges to allow more light in. After passing through the pupil opening, light rays reach the lens. This transparent, flexible structure uses tiny muscles and fibers to change its shape and thickness, allowing the eye to converge the light rays. This refractive power gives us the ability to change our focus from objects close to us to far away in the distance, then back again. After the light rays exit the back side of the lens, they proceed through a gel-like substance in the center of the eye called the vitreous humor. Vitreous helps the eye maintain its spherical form and shape. Finally, the light rays converge to a focal point on the retinal surface. Retina is the part of the eye similar to film in a camera. It is a very light-sensitive and complex tissue, wallpapering most of the wall of the eye. It is filled with hundreds of millions of receptor cells that capture the light rays, convert them into electrical impulses, and transmit them through an intricate system of nerve fibers to the optic nerve. These electrical impulses then travel along the optic nerve to the brain, where they are interpreted as the images we see.
So that's how you saw this is how the eye looks in the front, and this is the cross section. And everything has to be transparent. I wish our politicians learned that the cornea, the aqueous humor, the lens, the vitreous, and then only the image falls on the retina. An optic nerve is like the electrical connection for the brain, where all the images are processed in the brain. So that is why if somebody has an accident in the back of the head, and they can have a loss of vision called cortical blindness. So these are the retina which we have seen, and this is an instrument which we use for the ophthalmoscope to check the back of the eye. And this is a close-up. We are using a condensing lens, and so the retinal detachment is one of the layers, 3 layers: retina, the choroid, and the sclera, which is the white what you're seeing outside. The retina gets toned and then falls like this, and you see here the diagram, and that's the real picture, which is marked as retinal tear and retinal detachment. And then there are 2 layers of separate. Retina has 10 layers, and this is a separation of neurosensory layer from retinal pigment epithelial layer, which I'm seeing with the you can see in the layer. Where there's an instrument called OCT to detect that. So that's why this becomes expensive for investigation and surgery. And this is a retinal detachment where the film in the camera is come off, and that's how the vision is gone. And this is thanks to Dr. Prasanna, who came as a visiting fellow. He wanted to be an engineer, but he became an ophthalmologist. He's a 3rd generation ophthalmologist in Trichy. So he has made this animation. I just told him I'm giving a talk to Rotary. I want them to understand what is retinal detachment. You'll see the same as what you saw in the previous video, which is made in a company called Eye Imagination, which I bought. And this is made by our own Indian, Dr. Prasanna. So this is how the layers are, 3 layers. And that's the retina, which is seen as a translucent layer. Retina with the lines, what you see is the blood vessel, and which collapses when the retina detaches. This is how you look when you dilate the eye and check the retina. And the layer of the retina detaches. The film falls, you can't see. And the same thing, how you can. And then we reattach it, which he has made it in his own animated way. But I'm glad the retina doctor, he's an eye doctor, who has made this with his engineering team. He has got a moving image team. Thanks, Prasanna from Trichy. So there are 3 types of major detachment called commonly, which Redma means tear and G means origin. So the tear producing detachment called retina. In diabetic, retina is pulled like this it pulls, and that is a traction detachment. And then there's a thing called serous detachment. As you see here, fluid gets accumulated between retina. I'm not going into the detail due to inflammation of the back of the eye. These are the various high-risk patients. Mainly is the aging and myopia. This is what I want you to know. And because a lot of things are there. And did you know that retinal detachment can happen to anyone? Can you hear now? Is it better, Swati? Swati, is it better? Okay.
Yes,
So,
it's better.
retinal detachment can happen to anybody. One is in any person above the age of 50, or myopia, any age, or injury. So the main thing is floaters happening, and there's this happens 1 out of 10,000, and there usually happens more than -6 number if you have. Olden days, following cataract, they didn't put lens. It's called aphakia. And if you have weak points, which I'll be showing you now, and this is vitreous, when it gets separated, it can pull the retina and produce a break and produce detachment. And that's what you see here. Normal retina. Here you see like a water, like the retina is a translucent tissue, like a mop in the back of the, and that is lifted up, and then and if that lifts up like this, you can't see, and that's why the retinal detachment. And these are arrows which are showing retinal detachment, and this is a cross section showing the retinal tear and retinal detachment. This is a real-time photograph taken with the first 7 or 8 photographs, and we stitch the photograph. I'm sure you will be seeing whoever is checked that no photography. We stitch photograph and make a collage like this from optic nerve center to the periphery. And this is a detached area, and this is retina where you see through the translucent retina, the reddish one, that's the choroid, the second layer. And this is all complicated retina. Giant, we call it giant retinal tear, and totally those sort of eyes were problematic in managing, but now the technology is improved. We used to put the patient upside down under general anesthesia. Me and Dr. Badrinath used to operate in 1984 like that. That is because his mentor, which originated in Boston, were doing. Now we have technology where we can do it under local anesthesia without turning, and that's how the retina can be attached. And that was a pre-operative photograph, and there's a post-operative photograph, and this is again behind the retina. There are yellowish things seen, that is the subretinal band, because this patient is delayed, particularly children. When they have a loss of vision in one eye, they don't tell the parents because they're afraid of telling. Maybe the mother will punish or father will punish. And when they come for a routine checkup, you will find there's no vision. And then there's a total detachment with subretinal scar. And this is a fresh detachment. You see like a bullous fluid, and this is a reattached retina after surgery. And you can see the laser mark, and then the lower part has a lot of tears, and this is indicating that it's a complicated retinal detachment with a scar tissue. And these are the people who have recurrent detachments. And the other type of detachment, which I said is traction detachment, is mainly because of diabetes and injury. And this is what it looks like with a fibrous tissue contracting the retina, like this is the tissue retina, and it will be contracting, tissue will contract like this. So our idea is behind the membrane and then do the surgery and to reattach. And the other is serous detachment. Is a diagrammatic way of showing. The blue color shows the fluid getting accumulated without retinal tear, and that is exudative detachment. And there are several causes, as I mentioned. Inflammation is one. And then, so any patient, we do these are the symptoms. Suddenly you see black spots, and this is a normal vision, and you see one side is suddenly coming, the vision coming down, and that's how the retinal detachment will face. So examination, I showed you, we use an instrument called the indirect ophthalmoscope, apart from the various other, and that's how we can see up to center to the periphery of the retina. And these are the peripheral retinal weak points, which may happen in a myopia patient. Anybody wearing glasses with minus number, whatever the number is, we may have to check. They may have weak points like horseshoe tear or a lattice degeneration, or a lattice degeneration with a hole or a tear. So one of that, they may need a preventive treatment, and that the retina specialist would decide. I'm happy Dr. Rumi Jahangir is in the line, and these are the various tears. And this can where we can do the black spot, what you see is the laser done to protect that retinal hole becoming retinal detachment. And this is a diabetic eye, where angry looking fibrous tissue on the surface of retina, which bleeds, where we have to do laser. And that's where we have made a big campaign, and diabetes and eye is a separate topic by itself. And then this is the refer when a patient has a flashes of light, floaters of light, or a visual field loss coming, or any of in a examination also you can find out, or any blurring. I think it's an emergency, whether it's a Sunday or not, you should visit the hospital, whichever is open, retina specialist. And as I mentioned, we use the indirect ophthalmoscopy to check just way how to examine and how to prepare a patient. And I myself counsel to the patient. So the main thing is that caution when you have the problem is to report to the doctor immediately. So the main thing, these are the tests will be done, and can be done. We don't have a view, and that's why these are the prophylactic treatment I mentioned. This is a surgery where you see the muscles are tagged, and then we do the surgery by putting some rubber from which I'll be showing a video. And these are some surgery will be created in some, and this is in traction detachment. So this actually the video, which is about 6 minutes, but I think I have 6 minutes still. So this will show you 7 minutes to go, 20 minutes. So this video is very good. That's why I took it from YouTube. And so this is the European Vitreoretinal Society, which I'm part of the as a member, and we do programs together between India and the European Vitreoretinal Society. It's not working. Yeah, okay, it's come.
If there is a strong adhesion between the retina and the vitreous, the posterior vitreous detachment can cause attraction on the retina. If the retina itself is fragile at that particular point, this can lead to a retinal tear, which will allow the intraocular fluids to go through and detach the retina.
So this is what is the vitreous is a transparent gel. When we see the vitreous word in the flush tanks and the wash basins, many people may not notice it because what the mind does not know, eyes do not see. The word vitreous is a glassy substance, and that's the vitreous, which is a transparent one, which can pull as a part of aging because the vitreous is attached all around when you're born.
No. In the large majority of cases, there is nothing that indicates that a retinal detachment will occur before it actually happens. Physical symptoms perceived by the patient, like flashes of light, shower of floaters, or a loss of peripheral visual field, that the patient will not notice most of the time the central vision has been affected. Without rapid surgical intervention, preferably between 8 and 15 days, the retina can become retracted because pigment cells will start to form membranes over the surface of the retina. When the retina is retracted, surgery becomes much more complicated and the chances of healing are severely diminished. The first goal of surgical treatment is to stop the fluids from passing through the tear by plugging it. The pumping done by the pigment epithelium allows the retina to be reattached. To do this, the surgeon first needs to find all the tears or holes, no matter how small, in order to induce an inflammatory reaction on the edges of the holes or tears by cryopecty or laser. This reaction will act blue when the tear will be pushed against the pigment epithelium. This can be done in several ways. The doctor can reshape the sclera, pushing it against the tear by doing a scleral buckle. Using an explant suture to the sclera.
So this was an age-old surgery. Even today it is valid, because when you do an excellent surgery as the earliest, that's why I give a talk called Fine Art of Sterile Buckling, because this is a age-old surgery. Means 1930s they started and refined in 1950s, and we have further refined. Now the modern is will do vitrectomy, which is I'll be covering, but scleral buckling, if you do early, is the best.
He can do an internal tamponing by pushing the retina against the pigment epithelium and then injecting a bubble of gas into the eye.
So because of this gas, we actually make gas push the retina towards the back of the eye. And that's why we do positioning. If the gas is on the top, the patient has to sit erect. If the gas is in the bottom, the patient has to put the head down, because the gas will work on the physics where the gas will support whichever is the floating position.
This bubble will then be absorbed naturally. For complicated cases, a silicone bubble is sometimes used instead, though it must later be removed. Lastly, he could remove the vitreous tractions that caused the detachment in the first place, thus giving the retina back its flexibility. This is called a vitrectomy, or removal of the vitreous. All of these procedures can be done together, as well as with other complementary steps, like membrane dissection, or removal of the fluid underneath the retina. The failure rate of the first surgery is always present, because a surgeon cannot completely account for the range of outcomes that can occur with each individual detachment, especially if it is advanced or involves complications. It is necessary to restart procedure, given that since a healed state is not maintained, the condition continues to contribute to permanent vision loss. As soon as you leave the clinic, you will place eye drops in your eye. The name of the eye drop, the frequency of use, and the duration of the treatment will all be stipulated by your original prescription. Certain treatments against pain or inflammation can also be obtained. If a gas bubble was placed in your eye, your surgeon will ask you to maintain a certain head position for a few days. The goal of this position is to allow the gas bubble to push on the proper part of your retina.
So some patients this way, some patient this way, some patient head facing down, and depending on where the retinal tear is and where we want the gas to support the retina.
This bubble will disappear by itself after several days. During this time, you will see a large black spot in your inferior visual field, as if you were looking through an aquarium. While the gas bubble is present in your eye, all travel by airplane is forbidden. To promote proper healing of your retina, it is recommended to avoid movements that can cause ocular shaking. Avoid reading and looking through the window while traveling in car or train. Avoid straining in sport. However, if the prescribed head position allows, watching television is permitted. Additionally, you will need to respect a few precautions for at least 15 days. Do not irritate your eye. Be careful using shampoo and soap, and do not use swimming pools. Avoid catching a cold.
So in India, I don't recommend them to take head bath or going out, even though in US they allow, because of the environment.
And avoid infected people. An ocular infection is a very serious complication which necessitates emergency treatment. If your eye experiences redness or pain, call your surgeon immediately. Your vision will improve progressively. It might be difficult to appreciate this recovery if a gas bubble is present. However, you should not experience a rapid shadowing of your visual field. If this occurs, phone your surgeon. A follow-up visit with your surgeon will allow him or her to judge the results of the operation. Know that the risk of recurrence is always present and that subsequent interventions might be necessary. If all goes well, you can...
So that's why my second mentor is Dr. Aditya Jyot Eye from Antwerp. He always mentioned, you have to tell the patient, any retina patient may need more than one procedure.
Expect a return to normal activity. Visual improvement will be obtained within 3 to 6 months after the operation. If present at all, any pain will progressively diminish.
So the prognosis, the ultimate outcome depends upon the time the retina is detached, the time you go to the doctor, eye retina specialist, the underlying mechanism of retinal detachment, and when the macula is involved or not. Macula is the centermost part of the retina and related inversely to the degree of macular involvement and the length of time the retina has been detached. And how can I prevent detachment? No person can prevent themselves except prevent injury, and then a normal activity you can do, and then or black spots or a loss of vision, you have to go to a retina specialist, preferably, or to any eye doctor, and not an optometrist or any optician. So it is important to get comprehensive dilated eye examination. And that is why I had a bad name in the 80s, early 90s, when I came from Madras to Bombay, because detailed examination takes time, and I don't do any other retinal thing, but everybody was making fun of me. Oh, you have to wait 4 hours and 5 hours. But every patient examination is back-breaking. And even today, my other researcher from Trivandrum, Amrita Institute, he said he is in bed rest because of the cervical prolapse. So that's the reason I will do exercise for neck, hip, and the back. So a detailed examination takes time, and retina examination is not a joke. And I think that's the reason a detailed examination is important. And then how can I prevent? And the only thing, if you have a symptom, you can do the laser or a cryo, which you saw, which is a freezing technique. And then if you have a surgery, this is what is a scleral buckling. And then these are the list of questions to ask. And maybe I will leave the questions when the question answers are there. You can decide when to ask. And then how do we cope up? So that is the reason we need to counsel the patient. And I keep telling entire staff to explain again and again. We give literature, printed literature, we give videos, we give YouTube videos every time, because educating the patient and the family is the most important. And then when to also get a second, this one. So I have made myths and facts here, because according to one school of thought, it was considered advisable to restrict myopic patient from bending down, reading exercise, seeing television, and carrying heavy weights to prevent retinal detachment. And this is a myth. And when I came from Madras to Bombay, it was a shock to me. So I wrote this article. So the latest belief is that, the latest is almost 40 years old now. The latest belief is that no such restriction is required. Direct injury should be avoided, and the person should periodically have the right check. Retinal detachment occur due to abnormal vitreous and retina relationship rather than reading, watching television, carrying weight, or bending down. And it's purely due to coincidence. And I explain to the patient that when you're using on a computer, you blame the computer. If you're a farmer, you blame when you're doing farming. And if you're a bullock cart, you're riding, and you blame the bullock cart. So there's no connection or flying. And then a retinal detachment, on the other hand, can occur even during sleep, and most of the time it may happen during the sleep. And restriction that we have mentioned about 6 weeks, or depending on the surgeon, they not to take head bath, not to put water, positioning, head down, head up, head side, are laid temporarily before and after surgery. Because if you have one day you're taking some time for medical clearance, you might have to follow some position, and after surgery for making the. So following that, a person can lead a normal life. And Mr. Shivanand said I should not tell the name. I've operated excellent sports people who are sports, national sportsmen, where they had a detachment, but after the surgery, I have made them go back to their normal sports routine. You're an athlete, go back to athlete. You're a football, go back to football, except boxing, because the people injure the eye with a thumb. And the best way to find your goal is to lose your path. Thank you very much for this opportunity. And so thank you very much. So I'm open for maybe.
Thank you, Doctor. Thank you. This was an extremely informative lecture. I think we've all become doctors after this. Are there any questions? Any questions on this issue? I'm not sure I can see. Let me ask a question, Doctor.
Yes.
You have said that there's nothing really that one can do to prevent it, and it is like it just happens. Is there anything nutritionally, like in vitamins or something, that one can do for the vitreous? Is there something that one can do nutritionally?
No, it's a very good question. Even the vitamin A, which is given in the growing child, is only for the development, and after that it doesn't have a role. And vitamin A has a role in the whole body for many things in the epithelium in the body. So there's no nutrition connection. This is a pure it's a pure physical relations of vitreous and the retina, which pulls the retina like that. So one thing is, if you are a myope, see, eye is like this. So vitreous, when it's attached and pulls, that you can't prevent. But when there's a weak point in the peripheral retina, or there's a hole, or in the family history there was a father, mother, or anybody had a detachment is not hereditary. But if a father, mother, the history is there, or a fellow eye had, if you have you should have a routine checkup. In the routine checkup, we find a weak point, we can do preventive laser. That's what I mentioned in the thing. So the main thing is, idea is not to make you doctors, but I think the idea is to be self-aware. And self-health awareness is very important. At the same time, no need to get scared. I think be positive, think positive, and same time, you have a complaint. There are a lot. Luckily, when I came from Madras to Bombay, I think only Dr. Jahangir and Dr. Ursekar were there, and now I think every pin code we have retina specialists. The only thing is you have to reach them immediately to get the best. And as I mentioned, any retinal surgery is complicated. We never use the word simple and complicated in the sense before. I think every eye surgery you have to take it serious, even cataract. And I call it, I think you have to take extreme precaution and do the best and expect the best outcome.
So the takeaway really is that after a certain age, there should be a yearly eye checkup, just in
Correct.
case there is something that could have happened.
Swati wants to ask a question. She has mentioned in the group,
Yeah.
in the notes.
Yes. Yes. Doctor, I would like to ask, a lot of children and people go in for laser surgery for the myopia correction.
Yes.
So does it weaken the eyes, and could it possibly cause retina detachment or something?
No, as I mentioned, the front to the back is a 24 millimeter generally. And when it is little 1 millimeter more, you have -3. 2 millimeter more, you have -6. And it's exactly like height. So the myopic eye compared to a normal eye can have a stretch, like the retina is stretched like this. And when you have a stretch, it can give way, and then a retinal tear or a hole can happen, detachment can happen. So the LASIK is or the any of the corrective surgery called SMILE, or even a femtosecond bladeless surgery will not make the eye weak, but you're only reducing the number. But the eye length you're not changing. The length is same. The vitreous pull can be same. So only thing is you have to check the peripheral retina, which I make it as a mandatory in our hospital, that any patient going for a LASIK should have a thorough retina checkup, and the eye should be perfectly normal. Myopia is not a disease. Myopia is a condition. That means somebody is 6 feet tall, somebody is 5 feet tall. It is not a problem. And only in so minus number is like exactly like height. And that is why the minimum age is 18, and the stability should be for minimum, the number should be for 2 years. And the corneal thickness should be proper so that the eye does not get weakened. So if we have a selection criteria, as I have proposed by both our All India Ophthalmic Society and this American Academy of Ophthalmology, if you follow the guideline, and the patient is also not like a fanatic and wants the LASIK somehow, if he understands and then discuss with the surgeon and then decide. And I mean, if there is myopia, as I said, 1 out of 10,000 has a weak point. So that has to be corrected. In spite of that, you can have a risk of detachment, which is again 1 out of 10,000.
Doctor, there's another question from Dr. Trivedi.
Sir, you told retina detachment is a real emergency, and we find it really difficult for non-affording patients who go to BMC hospitals and on. So can you throw some light on that? How can we help out these patients who really, first of all, they don't have the right guidance, and if they want to go also, they are monetarily very weak?
Yeah, so a very good question. So when I came from Madras to Bombay, that's why I started charity. But later, Dr. Lahane came as a head of the department in JJ Hospital. So I used to operate free those patients. And now I'm happy to say, after our CM has come, and I think before that itself, in KEM, we used to take the mobile van with the instruments. Now KEM is totally well equipped. Nair Hospital, thanks to Lions Club, has donated. Maybe the Sion you should donate. I was a faculty there, and actually they are not having enough equipment. It's a municipal hospital. Maybe the Rotary Club should donate a department of vitreoretinal surgery, and then I'm sure we can train them free. And that's what Shankar Natarajan is doing, Arvind is doing, and I'm doing. We have trained hundreds of retina doctors who are doing all over the country, and I think this affordability is a point. And as I said, all equipments are expensive. So KEM has, where Dr. Jahangir was a faculty, and now Nair Hospital has, where our Anjali Nicholson was the head of the department, and she's trained in Shankar Natarajan. And then Sion doesn't have. And JJ has 2 or 3 people trained in Shankar Natarajan, 4 of them. Dr. Preetham Samant leads there, and they do it free. And you can go immediately. There's awareness has to be created in the public by Rotary or by the press, directly saying that what is retinal detachment, and if you have detachment, what to do.
Yes, that is a very point. Yes.
Can I ask the question, Dr. Dastu?
Yeah, please go ahead, Adi. Adi, please go ahead.
Thank you. Professor Natarajan, Dr. Adi Dastu,
Yes,
classmate of Rumi Jahangir at the KM Hospital. One became a gynec, one became ophthalmologist. So we are both good in both the departments. Really enjoyed your talk. I wanted to know what in your opinion, in yourself, made you get that Padma Bhushan and the award. Because see, we gave you the Kimpro award. I'm in the Kimpro Trustees board also. because your work outshines other people, and there must be some secret you're holding back, or behind the bubble there must be something which is causing you. Because I thought you'd tell us a little about your secret of being an outstanding ophthalmologist today in this country.
Yeah. So I actually follow the movie Three Idiots before the movie came. Follow excellence, you'll be successful. And that's what I learned from Dr. Badrinath. So he said 99% hard work. I changed it to 99% passion and with love work. That's what I did in Bombay Hospital. And when I came from Madras to Bombay, both Dr. Rumi Jahangir and Dr. Ursekar welcomed me with open hands, even though the management could not understand what I want, but they supported me. And I did 100 vitreoretinal surgery in 88 a month. And then I left in July 5th, July 90, only because they couldn't give me all the equipment. I told them, what do I do with the hands? First month, they gave me a room, with a big room with a big wash basin. I told that chairman, what do you give me a wash basin? I am not going to use that. I need a good space. And I put a couch there. It was difficult to take the patient up. So I modified it. So I think the main thing is this. I'm glad I give now motivation talks to 10-year-old and 18 years old in the Leo Club and maybe Rotary Club. My dream is to inspire everybody. I started with 2,000 rupees salary and 4,000 rupees I was doing in Shankar Netralaya, the maximum number of retina surgery in the world. And thanks to my mentor, Dr. Badrinath, who gave me. And when I came to Bombay, the first patient was referred by late Dr. Kanti Modi from Jaslok Hospital. Then I operated the medical director of Jaslok Hospital, Dr. R.D. Lile. Then I think whatever the retina problem, where nobody could do, even today I can do, but I don't know the result. I can. So the secret is, there's no secret. It's an open book. And that's why I blabbered in the beginning. So it's an open book. That my life is open book, and anybody can ask me. And I'm happy, sir. At your age, you're asking. I want to joke here. I bought a gynec hospital, and both has fundus, both gynecology and retina.
Absolutely.
So finally, I've converted the gynec hospital to eye hospital. So
Excellent
I hope
answer.
I've answered your question, sir.
Yes, you absolutely answered very well. Actually, we both have the fundus. I agree with you, and I really appreciate the work you've done. You've done an excellent job. Applause to the Kanti Modi. You mentioned Kanti Modi. My cousin, my nephew had a detachment in 1969 or 70. Kanti was the doctor in Jaslok Hospital. We called him, and he did a laser at that time. So Kanti also was quite ahead of his time in those days.
Correct.
Thank you. Thank you. I think we have
right path.
I think we have the time for one last question, which is by Dhruv. What is the reason for dryness and itchiness in eyes in elderly people, and what is the cure for it?
Anyhow, it's not related to the topic, but still it's a common problem. One of the common reason is there's using the computers, then the mobile now because of the COVID, everybody's in the WhatsApp. So I called it a WhatsApp vision syndrome, and also digital because continuously you don't blink. And second is if you're in an AC blast directly with a AC blast or the fan, and a dirty environment, even dusty environment. And if you have any disease like rheumatoid disease, you can have a dryness, or sometimes some tablet, some medicine which can have a side effect. So and then aging also, the lacrimal gland may not secrete enough, and that can produce dry eye. So if you have a dry eye, the treatment is there are some.
He told me he's getting it 2 days apart. 3 days ago, I asked him.
Somebody
Akshay?
Sorry. So I think the treatment is the
Dr. Natrajan.
Recently my cornea specialist, Dr. Kavitra, said we are doing dry eye investigation where we investigate with a list of tests, including vitamin D. And she found vitamin D deficiency is associated with dry eye. And I'm also doing a PhD on vitamin D deficiency and diabetic retinopathy. So vitamin D is very important. And unfortunately, it has been declared by all over the health specialists is vitamin D in a sunny country like India has a maximum in vitamin D deficiency compared to the Europeans and Americans. So all of us have to correct our vitamin D. And if required, then you have to go to the eye doctor and take the but a dry eye test can be there, which can be tested, and then decide what treatment to be done. You are muted, madam. Sharna's madam.
Yeah, it seems to be some kind of anomaly, because if vitamin D in a sunny country where you get vitamin D from the sun, why should we have the highest levels of deficiency?
The absorption.
One is we have forgotten to go in the sun. Second is we wear suit like this. Like the only thing you should see how Swati comes to the gym. You have to do like that so that most of the sun comes on us. And people don't want to be in the sun. They are in the AC all the time. I don't know. There is something to do with genetics also. I'm not sure what it is. That's why I'm also doing a genetic, that's beyond this talk here. But vitamin D is definitely low in India. So whatever you say and whatever you take, it also doesn't get absorbed. So you have to take properly, go to an internal medicine person, find out, or a nutrition person, how to take vitamin D. Because it is not simple. Just take one every week, one sachet, and it works.
Thank you.
It
Thank you, Dr. Natrajan, so much. Now I'd ask Dr. Akshay Batra to give the vote of thanks.
Thank you, Dr.
Maybe
Natrajan.
can I have one comment from Dr. Rumi Jahangir? He is like my teacher.
Dr. Rumi?
Yeah, thank you very much for coming and enlightening us on this excellent presentation you made, and you've been a great inspiration and a boon for the city to cure all the retinal diseases. May God give you a strong and healthy life to carry on with the good work that you have always been doing. All the best to you.
Thank you. Thank you. And Rumi
Thank
is
you,
my,
Rumi.
I still remember the day one I came, and Dr. Rumi Jahangir and Dr. Ursekar both supported me in Bombay Hospital. And I'm really thankful to you, sir. And even after that, even today.
Thank you. Lovely.
So, Dr. Natrajan, you couldn't have got a better thank you than that from your mentor. So whatever I do will only pale in comparison. But I'd still like to say thank you on behalf of our club. And, you spoke about dry eyes and about being on the computers for too long. And I'd just like to remind all our club members that you now have a chance to rest your eyes starting the 9th of November when we get into physical meetings. So please join us for the physical meetings again, lunch with us, and enjoy being back at Rotary the way it used to be at the Taj. So we look forward to that. Dr. Natrajan, once again, thank you for spending the afternoon with us. On your behalf, the club shall plant 10 fruit-bearing trees at Nilmati Dandwal Gram Panchayat.